Hello everyone and welcome to my YouTube channel. So in the previous video we saw about the venous drainage of the lower limbs. We saw about the superficial, the deep and the perforating or the communicating veins. So today we'll see about varicose vein in more detail. So if we can recall from the previous video, varicose vein can be defined as when a vein is elongated, when it is dilated and tortuous, we say that the vein is varicosed, or we say that the patient is having varicose veins. So before moving into further details, let's see what happens normally in the venous system. So this is the superficial veins, this is the deep veins, and this is the perforators. So normally the blood that is present in the superficial veins, they drain into the deep veins. Okay, so from here the blood enters the deep veins, then enters the systemic circulation. We can see this is the soleus. So soleus is also called as the second heart of the body. So the blood that is received in the deep veins through the perforators from the superficial veins, okay, when this muscle contracts, the blood moves upwards. Okay, and whatever you can see the markings here, these are your valves. Now these valves that is present here also in the deep veins, in the superficial veins also, they prevent the backflow of the blood. So when the blood is supposed to move forward, these valves, it prevents the backflow. Okay, and we also know that during inspiration in the chest or in the thorax, there's a negative pressure that is created. So this negative pressure pulls up the blood or sucks the blood. Okay, there are so many factors involved for a normal circulation of the blood. So from the superficial veins to the deep veins through the perforators, because of the contraction of this, it enters and also the intrathoracic pressure, the blood reaches the heart. So this is what normally takes place. Now if there's a problem in the valves here, okay, so either in the deep veins or in the perforators or in the superficial veins, okay, there can be a backflow. So we saw that here the muscles, that is the muscle here, when it contracts, the blood moves upwards and this blood is in great force. Okay, so for some reason, if the valves are incompetent here or the valves are incompetent in the deep veins, so perforator veins, sorry, so this blood that is in great pressure, it is supposed to, instead of going up, it enters the perforator veins. Okay, and because of which these veins can further get damaged. Okay, and if these walls are damaged, then this high pressure blood reaches the superficial veins. Okay, so this is called as a high pressure leaks. So because of the incompetent valves here, okay, when the blood is in high pressure, the blood goes in the opposite direction against these walls because they're weak. Okay, so if the tap is not closed properly, the water leaks. So same thing here, the tap doesn't close properly, and if the pressure is more, the blood which is in great pressure, it comes in the opposite direction, and this, which is the blood which is in great pressure, can damage or weaken the wall of the veins. So if this happens for a long time, it can become like this. In this picture you can see that the walls or the vein is elongated, or it is dilated in some places, and it is bent in some places, so it can lead to the formation of the varicose veins. Okay, so increased pressure can lead to the varicose veins. So to understand this better, just take the example of a rubber band. So a rubber band, when it is new, if you pull a little, it comes back to the original form in greater force and faster. But if this rubber band is stretched for a long time, okay, so if it is hooked at the two ends, and after a long time, maybe after 3 4 days, if you remove it, then you see the shape of the rubber band becomes loose. Okay, it becomes longer, and the elasticity is not that much. It doesn't hurt like when you if you pull it, and if you leave, it doesn't hurt that much. So the same thing happens in the leg, or in the veins. So the exact same pressure, the blood from with great pressure reaches the superficial veins, and also it can lead to the stasis of the blood. So these two things can cause the weakening of the veins and lead to the varicose veins. Now, if you see the causes, okay, so they say that a varicose vein is nothing but a penalty or that a person or an individual or humanity has to pay for the erect posture. We see that there are so many animals around us; they all crawl on four limbs, but here we walk on these two limbs. So the main thing is here there is a gravity that is acting. Plus, when the person is standing straight, the column of blood also exerts a lot of pressure on the veins. So that with the gravity can lead to the varicose vein. Second thing is we saw that the superficial veins are present in the subcutaneous fat or the loose fatty tissue. So if there's something which is very loose, surrounding the vein, and if the vein is undergoing a lot of pressure, this fat around it does not give any kind of support or strength, and the veins are at the wrath of the pressure, or they have to they dilate with the pressure. So the loose fatty tissue around doesn't give any kind of support, and this can also lead to the varicose veins. Now if you see the types of varicose veins, we have primary, secondary, and congenital. Now primary is mostly related to the defect of the walls. Okay, so if there's a problem of the walls, it can lead to the varicose vein or the primary varicose vein. Now, this damage or defect can be congenital causes or acquired cause, and it is usually the thrombosis or inflammation. Okay, so this damage the walls. Now, if the saphenofemoral valve is damaged, it can lead to the varicosity or the varicose vein, the long saphenous vein. If the saphenopopliteal valve is damaged or it is incompetent, it can lead to the varicose vein, the short saphenous vein. And if the perforators, if these veins are not, or the walls of these veins are not competent, it can lead to varicosities of either the long saphenous or the short saphenous vein. Okay, so the main reason here is a defect in the valves that will lead to the primary varicose vein. Now if you see the secondary varicose vein, here the main reason is the obstruction. Now if you see, if there is an if yeah if there's an obstruction here, okay, and the blood has to move up. If there's an obstruction here, the blood has no way to move up here, so it has a negative pressure, or it has a reverse pressure or a reverse flow, and this can damage the walls and it can lead to the varicose vein. So secondary varicose vein is because of the venous obstruction. Now venous obstruction can be direct or indirect. Direct, especially in the case of deep vein thrombosis. So here a thrombus is found within the vein which blocks the blood flow, and it can lead to the varicose vein. Other factors, if you see the mechanical factors, now this causes varicose vein indirectly. So suppose there's a tumor in the pelvis, or there's a fibroid in the pelvis, or in case of pregnant females. So what happens in all these things, in all these conditions, the veins that surround these organs, the enlarged organs or fibrosed structures, they get obstructed, or they put a pressure on these structures on the veins, and it can lead to the obstruction. Now commonly we see that when we are watering the plants, and if the vehicle goes across the pipe, or if it is on the pipe, the water speed reduces, and the pipe at the tap end may just fall off. Okay, so there's a reversal of the pressure. So same thing happens here, but here a varicose vein is formed in this case. Second is the hormonal cause. So progesterone has some role in the formation of varicose veins, and this is more commonly seen in the multiparous, or women who have had many children. Okay, so many children or multiparous women are at a risk of having varicose vein. Now, arteriovenous fistula can also cause the formation of varicose vein. Now, this can be formed because of trauma, or when there's a need for dialysis, this particular thing is created, and this can cause varicose vein. Now, how this forms is, now see, usually this is the artery. It branches into the medium arteries, and then the small arteries, arterioles, capillaries, which supply oxygen to the tissues. And then once the blood is, the oxygen is removed, or it is used up, it enters the small venules, then the medium branches of the veins, and then joins the larger veins. So this is what is happening normally. The blood is very nicely distributed, and the pressure here is minimal. Now, in case of trauma or in case of dialysis, what happens? The arteries and veins, they join abnormally. Okay, it's also called as arteriovenous malformation. Okay, so now you see that this is a very gross connection between the arteries and veins, or that there is this if you see this lumen, or if you see the caliber of this particular vessel, it's a very big when you compare to these small vessels. So the blood that flows here is also of great pressure. Now if great pressure is there, we know that it can lead to the weakening of the walls of the veins, and over a period of time this can lead to the varicose veins. So this is why an arteriovenous malformation or fistula can cause um, varicose veins. Next, you have the a retroperitoneal fibrosis or lymphadenopathy. Now, what happens here is, now we know that there's a peritoneum that overlies the abdominal structures, but there are certain organs and structures that is lying behind the peritoneum and between the posterior abdominal wall. So here there are some arteries, there are some veins, especially the inferior vena cava, the renal vein. So many veins are there. Okay, so if there is a fibrosis or if there is a lymphadenopathy, so this is again a mass occupying or a space occupying lesion, and this, when it compresses the veins, it can lead to the obstruction and it can lead to varicose veins. Again, iliac vein thrombosis is an important cause for varicose vein here, because this iliac vein ultimately forms or gives a rise to the femoral vein, and we know that femoral vein is connected to the saphenous long saphenous vein, and it can lead to the varicosity if there's a thrombosis here. Okay, so this is secondary causes of varicose vein. And we also have a congenital variety. Now this is again because of the arteriovenous fistula, and usually commonly seen in people who are aged 20 years and below. So these are the types of varicose vein: primary, secondary, and congenital. Okay, now if you see the predisposing factors, now prolonged standing is one of the major causes or risk factors, you can say, for developing varicose vein. Now, as we saw in the previous slides, that if the person is standing for a long time, one thing is the blood forms it is in the form of a long column. Okay, so that is one pressure. Secondly, we have a gravity that is acting against this blood column, okay, which makes it more difficult for the blood to flow upwards. And prolonged standing, now see what happens in prolonged standing is the patient is stationary, doesn't move around, just standing. So the muscles in the calf region, they don't contract. If they don't contract, it can lead to the blood doesn't move upwards. So long time stasis or accumulation of the blood in the same position, uh, it can lead to the weakening of the veins and can cause varicosity. Second thing is obesity. Now we know that the veins are present in the subcutaneous fat, and in obese people, this fat is more. Okay, so if there's more fat, that means the structural integrity of these veins are poor. Okay, or the support that they get around these veins is lesser, so that can lead to varicose vein. Old age, like every other structure, the veins also get weak and old as age progresses, and that can lead to varicose veins. And surprisingly, even athletes are prone to get varicose veins. Now, why athletes here? Because now, as we know that when the athletes run, the soleus muscle, it contracts faster, it contracts more vigorously. Now, because of that, the blood is also pushed upwards, with a greater force. Now, sometimes this can have enter the perforating veins, can cause a damage of these veins, or the walls of these veins can become weaker, and great amount of blood with greater force enters the superficial veins, more pressure, more accumulation of blood. Now this can lead to the varicosities. Even the rickshaw pullers, now nowadays we don't see them as such, but previously even the rickshaw pullers were prone to develop the varicose vein because of similar phenomena, the greater contraction and the more frequent contraction of the soleus. Now you see the clinical features. Mainly the person will come and tell, I'm having a lot of tiredness of my legs and a lot of aching sensation in the legs, especially in the calves. And this is more in the end of the day. Okay, so why this is happening is because by the end of the day, the pooling of the blood becomes more, the pressure increases more, or the backflow of the blood is more, because night he's anyway lying down and the venous return is fine. But in the day, the patient is, or the person is either standing or sitting. Now this can slowly it causes the accumulation of blood, and it can cause the tired and aching sensation. Okay, same for the, he can also complain of edema again towards the evening, same phenomena, because in the night the venous return is fine, but in the day, because of standing and sitting, the blood usually it accumulates in the leg, and that can cause edema again. Okay, so ankle swelling towards the evening, tired and aching sensation in the evening or in the end of the day, and the patient may also complain of sharp pains in the grossly dilated veins. So what happens is, any structure, whenever they're they are dilated or they're stretched, this can cause pain. Okay, then there's one more very important symptom or very commonly occur encountered symptom is the patient complains of cramps in the night. Now why this happens is again the same reason. When the patient lies down, the venous return improves. There is a stretching or dilation of the perforators especially, and when these veins dilate, the muscles around get stimulated, and then this can cause the cramps. Okay, the patient may also complain of very severe or bursting pain, especially at the site of incompetent perforators, and this is especially in the walking. Again, why? Because the soleus is contracting, and whenever the blood moves, in the wrong direction with the force, that expands or stretches the perforators, and that can cause the pain. There can be times when the patient may not have any symptoms at all, but only the appearance of the dilated and tortuous veins. Okay, and there may be associated symptoms of ankle swelling, and we saw the reason why it takes place. There can be eczema, there can be itching, there can be pigmentation and ulceration. Now why this eczema itching takes place is, see, when there is a accumulation or stasis of blood, the blood leaks out. Okay, so when the blood leaks out, the RBCs also, they come out, and these RBCs are disintegrated, which causes the formation of hemosiderin. Now this hemosiderin is responsible for the formation of the pigmentation or the black or the brown discolorations, and this can also cause itching. Okay, now why eczema? See, already hemosiderin causes itching, so the person scratches, and that can cause a local damage of tissues. Now, eczema, why? Because now we see that in varicose veins, there's a pooling of blood. Okay, because the veins are not competent. So even though there is a certain movement of blood towards the heart, some blood always remains, or stasis of blood takes place, because of which the tissues are not there is no replenishing or refilling or refreshing of the blood in the same place. So the same old blood stays there, the oxygen is not delivered to the site of the tissues. That can cause a damage. Okay, so there's a lysis of the tissues because of less oxygen. Because of itching, there is scratching which causes damage, and this can lead to eczema. If this is not controlled, then this can lead to the ulceration. Okay, so this is the clinical features of the patient affected with varicose vein. And in the history, when you ask the patient will tell that my job or my occupation requires sitting for a long time. Okay, so you may get this as a information or a history. Now, if you see the examination part, on inspection, you can see that there are many places where you have the varicosities or the prominent veins, or it can be in only one or two areas. Now, if this takes place at the saphenous opening, it is called as saphena varix. Now, this has a few features. That is, when the patient is asked to cough, a thrill can be felt, and when the patient lies down, the prominent veins or the saphena varix, they disappear, and a kind of fluid thrill can be felt in the long saphenous vein when you tap on the saphena varix. So tapping on the saphena varix you can feel a fluid thrill in the long saphenous vein in the lower part. Second thing is, try to see whether it is the long saphenous vein or the short saphenous vein that is affected, or it is both that is affected. So varicosity of what vein is present, you should see. So next is, look for eczema, pigmentation, or ulceration. We saw why these things take place. So look for these signs also: eczema, pigmentation, or the ulceration. So now, next, there are certain special tests that has to be performed in case of a person with the varicose vein. So the first one is the Brody-Sprendelenburg test. Now this is to check for incompetency of the saphenofemoral valve or the communicating veins. Now ask the patient to lie down. Then secondly, ask the patient to raise his leg so that there's emptying of the veins, and apply a pressure using your thumb. Now here two things can be done. Now after this second step, you ask the patient to stand up and you release your thumb. Now what happens is, when you release a thumb, if the blood flows very immediately, or as soon as you release, the blood fills the veins or the prominent veins appear, then we can say that the saphenofemoral valve is incompetent. Second step is, ask the patient to stand, but here what happens is, you are retaining the pressure, sorry, retaining the thumb that you placed here. Okay, now here what happens if the veins fill up, this indicates the incompetency of the communicating veins. Okay, so two ways are there. One is with the thumb placed and with the thumb removed. Okay, so this is Brody-Trendelenburg test to check for the saphenofemoral valve and the communicating veins if they're incompetent or not. Second is a tourniquet test. So here it is a variant of the Trendelenburg test. Now here what you have to do is again ask the patient to empty the, erase the leg so that it empties the vein. Then a tourniquet is tied either in the thigh or at different levels of the leg, and then ask the patient to stand. Now here what happens is, if so this is a tourniquet, this is the vein. If the vein fill up above the tourniquet, then we can say that the perforators at the level of, above the tourniquet is incompetent. But if the filling or the prominent veins appear below the tourniquet, we can say that the perforators below the tourniquet are incompetent. Okay, so here what happens, anyway the superficial vein is uh, tied up, or it is pressure is applied. So here not the superficial vein, but from the perforators the blood fills the superficial vein. So this is a test to check for the competency of the incompetent veins, the communicating veins. Next is you have the Pratt's test. So here is again to know the sites of the leg perforators. So in the first step, what you have to do is you have to take a S-mark bandage. It's nothing but it's very similar to a crepe bandage. Now here you have to tie this bandage from the toes to the groin upwards. Okay. Once you do this, you have to tie a tourniquet here. Okay. So that it empties the vein. After that, you have to remove this bandage, and then you have to tie this particular bandage from your groin to your toes. So at the side of the perforators, they kind of blow up, or a bulge can be seen here. So this gives you the sides of the perforators. Second is your Perthes test. Now this test is to check for the deep veins, if there's any problem in the deep veins or not. Okay, so here the patient is, a tourniquet is tied around the upper thigh, and then after tying it, we have to ask the patient to walk, and he has to walk quickly. Now here what happens, if the deep veins and communicating veins are normal, okay, the veins shrink. But if there is a problem in the deep vein or the communicating veins, the varicose vein become more prominent. Now why this happens is, as we know that when the patient walks, the soleus contracts and the blood is pushed with a greater force upwards. But if the communicating veins and the deep veins are incompetent, the blood, instead of going upwards, it fills the superficial veins, okay, because of the backflow. So when the patient walks, the distension can be seen, or the varicose vein becomes more prominent. So next is the Schwartz test. Now this is seen in the long-standing case of varicose vein. So what happens here is, if you tap on the lower and long saphenous vein, an impulse can be felt with the other hand on the saphenofemoral or the saphenous opening. Okay, so this is only in the case of long-standing varicose veins. Next is the Maurice test, or the cough impulse test. So here, ask the patient to raise the leg so that it empties the vein, and then ask the patient to cough. So when the patient coughs, an expansile impulse is felt in the long saphenous vein. Now this indicates that there is saphenofemoral valve or saphenofemoral junction incompetencies there in the patient. Same thing, if you auscultate at this saphenofemoral junction, you can feel a bruit, okay, when the patient coughs. So this is the Maurice test, or the cough impulse test. Now Fegan's method here is again to denote the site of the perforators. So when the patient is standing, you know that the veins are more prominent. So mark those prominent areas or bulges as X with the pencil, skin pencil. And then when the patient lies down, these areas have to be palpated to find the gaps or pits where the perforator pierces and connects the superficial to the deep veins. Okay, so this is again just to check for the areas of the perforators, or the communicating veins. Other examinations is an abdominal examination to check for any kind of tumors or masses, or to check for pregnancy, as we know that they can cause a pressure on the veins, and it can cause secondary varicosity because of the obstruction. And usually in cases of pelvic tumors or pregnancy, you can see a lot of collateral veins on the abdominal wall. Now again, this is a compensatory mechanism for the obstruction. Wherever there's an obstruction, you see at at that area, a lot of small veins, they spread out. Okay, so collateral veins are seen, and this also gives a suggestion of the pelvic tumor or some kind of obstruction. Next is a vaginal and rectal examination, again to rule out pelvic tumors. So these are additional examination that can be done to rule out any kind of mass. Now investigations, if you see, there's a venography. Here nothing but again a contrast medium or a dye is injected. So here there are two types, ascending and descending. Ascending is when the patient is standing and a dye is injected in the lower portion near the medial malleolus and the blood moves upwards. So this is captured. And descending is the dye is injected at the femoral in the femoral vein in the in the upper thigh. And because the dye is heavier, this dye comes down and the x-ray is taken. So image can be obtained like this. So here you can see the varicose veins. Now methods like Doppler ultrasound and duplex ultrasound imaging, they help to find out the saprophemoral wall, the popliteal wall, the competency, if there's any reflux, then the perforators if they're competent or not, and the blood flow, the direction, the velocity of the blood flow, and general mapping of the veins can be done. Okay, so these are more advanced and modern techniques where you can find out if there is varicose veins or not. Next is the photoplethysmography. Now here what happens here, it detects the filling of the surface venules, okay, and by this it detects or it gives a reading of the pressure in the superficial veins. Now once this probe is attached, you ask the patient to do 10 dorsiflexion of the ankle. So ask the patient to move the ankles. So the venous pressure in the saphenous vein, it drops. As we said, when the patient moves his limbs, the soleus contracts and the blood moves upwards. So blood from the superficial vein enters the deep vein and then it enters the main circulation. So the pressure drops. Now ask the patient to stop moving his leg. So during this time, the veins refill. Now if there's any incompetent valve here or the veins which are weak, this refilling takes place faster. So this graph is different when there's incompetent veins and when the veins are normal. So this also detects any kind of varicose veins. Now, if you see the complications, now the main complications are thrombophlebitis is nothing but inflammation of the veins. Now, here what happens? The veins can appear reddish. They can be felt like thick cord-like structures, and the patient will have a lot of pain. Okay, so thrombophlebitis is one. Pigmentation, as we saw, the blood leaks out. RBCs are disintegrated into hemosiderin, which can cause the pigmentation. Second is dermatitis, again because of the hemosiderin deposition, the lack of blood supply or pooling of blood, which causes hypoxia or anoxia, tissue damage, and scratching. All of that can lead to dermatitis. Ankle flare is nothing but again the dilation of the veins in the dorsum of the foot. Okay, so that can give appearance of a flare. And there is a hemorrhage. So at the site of these prominent veins or the varicosities, they can rupture and can cause hemorrhage. Now ulcer, now venous ulcers are a very common and a very obstinate complication of varicose vein. And one more thing to remember here is varicose veins are usually seen in the medial side or the inner side of the leg. Okay, that is the medial malleolus. Now the reason for this is because you have more perforators in the medial side, and usually the medial perforators are the ones that get weak. Okay, so there is more pooling of blood or stasis of blood in the medial side, and that can lead to the uh, venous ulcer, especially on the medial side. Periostitis is if there's a long-standing venous ulcer and if it goes deep, this it can also involve the bone and it can cause periostitis. Calcification of the varicose veins are also a very common complication. Another complication is equinus deformity. So what happens here? Once the varicose veins are formed, I told you, the patient experiences pain, especially when walking. So what he does is the patient tries to walk on his toes so that there is minimum movement of this ankle and the knee. Okay, because of which the contraction takes place lesser. Because if he walks properly, the contraction of the soleus will cause a backflow in the incompetent walls in the superficial veins, because of which it causes stretching and can cause pain. So in order to avoid that kind of pain, the patient walks on the toe. and this over a long period of time assumes a deformity. Okay, so you can see one leg may be normal, the unaffected leg may be normal, but the affected limb, the patient may assume it in this way. Okay, and there can be shortening of the tendo-Achilles ligament also. Okay, so this is one more complication. So this brings us to the end of today's video. We saw the causes of varicose vein, the risk factors, the clinical features, the examinations, the complications related to the varicose veins. So thank you for watching this video, and we'll see you in the next video. Thank you.